Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. Proton therapy, a new treatment for cancer. Find out about it right now. My guest this evening is Dr. William Regine of the Proton Treatment Center of Maryland. Dr. Regine, welcome to Housecall.
Thanks for having me, David. Appreciate it.
My pleasure. So, briefly, tell our viewers about your professional background.
Well, I trained at Jefferson in Philadelphia. I had my first job at St. Jude, which was an amazing experience in Tennessee, and ended up working my way back. In the last 15 years, I've been at University of Maryland in the Department of Radiation Oncology.
Very
and
good.
I'm the chairman there.
Very good. Congratulations. So let's focus in on cancer, the big topic for tonight. And many of our viewers are aware that if somebody has cancer, depending on the type of cancer and the individual's health history, the broad brushstrokes of treatment options are surgery, chemotherapy, or radiation therapy.
Right.
Briefly tell our viewers what exactly is radiation therapy.
So the best way to think about radiation is it's the non-invasive form of surgery. So we use, generally speaking, X-rays or photon radiation, which most people what they're exposed to in the region, to deliver high-energy X-rays into a tumor. And interestingly, amongst all cancer patients who are diagnosed, 60% of patients get radiation therapy as part of their treatment. A typical course is a Monday through Friday and about 5 or 6 weeks of treatment. Non-invasive, people don't generally feel or see anything during the treatment, and most patients are outpatients while they get it.
And how successful is radiation therapy to treat cancers?
Actually very successful, and if you take all comers, we're curing now at least 60% of the patients that we treat. And for the patients who are not curing, important goal in cancer care is also how can you improve the quality of life related to any symptoms they may be having to their cancer. And radiation therapy, when that's a primary goal, effectively improves the quality of life in patients in 75% of the times when that's the goal.
Now, when you treat a cancer with photon therapy, radiation therapy, what happens to the organs nearby?
So great question, and that is the limitation, can be a limitation of photon or X-ray therapy, which we're excited about now having proton therapy to help with that. And what I explain to people, if I could take your tumor out of your body and just radiate it, I can cure every cancer. The limitation for photon X-ray radiation is that your tumor sits in the body that has some surrounding normal tissue or organ that can be a limitation for us, like if it's in the chest, the heart, the lung, the esophagus. If it's in the abdomen, it's the bowel, bladder, rectum, or in the brain, obviously normal brain tissue. So with photon radiation, that can often limit us. And the truth is, despite some really great advances in the last 20 years with photons, amongst all the patients who get standard photon radiation, there's still about 20 to 30% where that low dose exposure, because X-rays really just pass through the body, and thanks to some advances, we can concentrate it. We still get a low dose exposure that becomes truly significant in about 20 to 30% of those patients who get standard photon radiation therapy. And so we're excited now for this region, which people aren't aware is the second densest population in the country. We now have proton therapy. So we bring this new tool in our cancer-fighting toolbox, and what protons enables us to do, and those other 20 to 30% of patients, is really reduce the dose even more dramatically to surrounding tissue and overcome some of those challenges. And the reason you can do that with protons is protons, unlike X-rays or photons, are charged particles. So we can actually pick an energy deliver the radiation to the tumor in the body, and literally it deposits all of the radiation in the tumor with no dose going beyond the area that we aim at. And so for that 20 to 30% of patients, we now have this tool to offer for patients in hopes of improving their outcome.
Raises interesting questions. Have you found when you were using the more traditional photon radiation therapy, there were patient tumors where you said to yourself, if only I could give them a higher dose, I might get a better response rate, but I can't because of the collateral damage to adjacent organs?
Absolutely.
Where you maxed out your dose.
Yeah,
so to
absolutely. And, people say, well, can I get proton therapy somewhere? Why is this the only place? Well, the truth is the closest center to us is in Philly. And in our world, usually in treating a patient, it's typically a Monday through Friday treatment for 5-6 weeks. So while patients can make a drive up to Philly for a consultation, completely disruptive to imagine a patient's going to stop their life and then also find a place and stay in Philadelphia for 5 to 6 weeks. So given the population here, we're very excited that we can now offer that therapy.
Give our viewers a very brief science explanation. What is the difference between a proton and a photon?
So protons are charged particles where X-rays are not. And because they're charged, they quickly deposit dose within tissue, and you can pick an energy of charged particles. So when it gets to the point in tumor, it deposits all of its radiation dose, which you can't do with a photon beam. A photon beam you can come in with angles and concentrate it to a point, but you still have dose exiting beyond the tumor. And if there's a critical normal tissue like the optic nerve or the heart or lung, that becomes a limitation, right? We can cure more cancers if we can drive more dose.
Sure. When was proton therapy first developed?
So in this country, the first units were FDA approved in 1988. And now we are one of 25 centers in the country, but we're actually the first center on the East Coast that brings this new advancement in proton therapy. And that advancement includes the ability to first, while a patient is lying on the radiation table, to do something what we call image-guided proton therapy. And what that means is patient lies on the table, and the first thing we do is we have the gantry or the machine spin around the patient and take a CAT scan. And what that does, the CAT scan documents where the patient is on the table, and if they're slightly out of position or have moved somehow, immediately before the beam is turned on, we can correct that motion. And then the second thing we can check is if it's in a part of the body, such as the chest or the upper abdomen, when you're laying there for treatment, you're breathing. Yeah. Right? Because it takes a couple minutes to give the treatment. You're breathing, and when you're breathing, the tumor is moving. So by taking that image-guided proton therapy or CAT scan, you can now also correct for the tumor motion immediately before the beam comes on. So after doing all that, the next big advancement we've introduced with our Maryland Proton Treatment Center is something called pencil beam scanning. So the majority of other centers that have been built in the past would deliver what we call one splash beam of proton therapy. And really, while they stopped the dose delivery beyond the tumor, they couldn't conform quite as well to the exact shape of the tumor. And if you look at a video that we have, once the CAT scan is done, you'll see in this patient who has a lung cancer that the pencil beam then comes on, and you'll see it paint the tumor with the radiation dose layer by layer, almost like a 3D printer. It's amazing. So it conforms right to the shape of the tumor. The CAT scan, while the patient on the table, takes about 2 minutes to obtain. Then the beam comes on, and most patients need 2 or 3 beam angles to treat the tumor. Each beam delivery angle takes about 2 minutes. So in total, the patient right now is averaging about 25 minutes or so on the table in our treatment room, beams on for a total of maybe 6 or 7 minutes. They're laying for the scan. They don't feel it, they don't see it, and most of these patients, if they're working, just walk out and continue to work and feel pretty good after having gotten the treatment. You've really reduced the dose of some of those normal tissue that normally bring on some side effects. For instance, if you're treating head and neck cancer, right? Typically, especially now with HPV, head and neck cancer is an epidemic.
I should explain to our viewers HPV.
Sure.
What does that stand for?
So it's the virus that now people can be exposed to that leaves you more prone to developing head and neck
papilloma.
Yeah, exactly.
Yeah, okay. When you do the CAT scan pre-treatment, is it a 3D image of the tumor?
Yeah, well, it's a reconstruction of the 3D image of the tumor.
Right.
Yeah. And that was part of the aiming session that the patient had before that. So in the photon world, we developed that 15, 20 years ago. And while protons have been around since 1988, these advancements of taking a CAT scan and delivering this, what we call a modulated pencil beam, that's only happened in the last couple of years. And we're the first center where in every one of our 5 treatment rooms, we have that ability.
So not all proton centers are the same?
No, not at all.
And you have some of the newest, if not
Absolutely.
the newest technology.
We clearly have the most advanced form of proton therapy you can get.
Right. So if somebody is going to get proton therapy, how long are your treatment sessions compared to radiation therapy?
They're about the same.
Same amount of time?
Yeah. So 2 things when you're talking about the session. The individual daily sessions are about the same. One of the things we're excited about with proton therapy, given that the dose is even more concentrated and focused, what we expect is going to happen, and we're conducting clinical trials to demonstrate this, is instead of the typical 5 to 6 weeks that a patient needs to get their tumor treated, we're going to be able to shorten that to 3 weeks, 2 weeks, or 1 week, which again is a dramatic improvement for their quality of life in terms of less disruption. And from a societal point of view, it also should reduce cost of care.
Is this something that is covered by insurance?
Yeah, covered by Medicare, and we have a very unique center in that, given that we've created a center that's we would describe as a regional resource, where we let providers from other systems come in and treat patients. We have been able to allow our patients to get proton therapy at a cost-neutral pricing to standard radiation. We're only one of 2 centers in the country where every patient who comes in for proton therapy would get treated at the same cost as standard therapy across the street at our photon center. So right now, about 80% of patients who come in with their either Medicare or commercial insurance are approved on the first review. So it's been a great experience in terms of that, and essentially partnering with payers.
Sure. We have 1 minute left before we pause for the break, but you mentioned across the street your radiation center. Why would anybody at this time get radiation therapy when across the street is the proton center?
Yeah, it's a great question, right? So it's an expensive resource, and we have to be using it for the patients who are going to benefit most. And I want to say this clearly because we don't want to cause hysteria, Dave, right? The current modes of photon radiation that have advanced over the last 15 years is outstanding in 70 to 80% of patients. They're not going to gain some significant benefit from protons. What we want to care for is that other 20 to 30% of patients, and these big tumors anywhere in the body from the head to the toe, that 20 to 30% is who we want to focus on at the Maryland Proton Treatment Center.
Very good. Well, we're going to pause briefly for a public service announcement. When we return, more with Dr. William Regine from the Proton Center and exciting advances to treat cancer. We'll be right back.
The odds of this boy achieving his dream in fashion? 1 in 23 million. The odds of having a child diagnosed with autism? 1 in 68. I am Tommy Hilfiger. Learn more at autismspeaks.org/signs.
We're back. My guest this evening is Dr. William Regine from the Proton Treatment Center of Baltimore. Dr. Regine, when we were pausing for the break, we were discussing this exciting therapy, proton treatment for cancer. Briefly tell our viewers how this fits in when somebody has cancer, when they're being considered for surgery or chemotherapy or radiation therapy.
Sure.
How do you fit in this? Is this something that is used instead of radiation therapy? Is it maybe used for people that have maxed out radiation therapy and you're considering this as a plan B?
Right. So First of all, our Proton Center is fully integrated with the University of Maryland Greenebaum Cancer Center. So we have every tool, including the best of surgery and chemotherapy, in taking care of a patient. Proton therapy should be used as a tool that can be complementary and help where those other therapies might have some limitations. So it may be in patients who can't have surgery, or maybe patients had surgery, but not all of it can be cleared, so we're going to be using it in conjunction with surgery. Many of our patients, probably at least half, proton therapy will be given with chemotherapy. The nice thing that proton therapy does is, remember I told you the standard radiation does this low-dose exposure to normal tissue. Well, when that normal tissue is getting both low-dose exposure and chemotherapy at the same time, a lot of acute reactions can happen. Proton therapy has been able to reduce that reaction. So it's been great in giving the patients who are getting chemotherapy. You brought up the question about patients who've been previously irradiated. So interestingly, almost 10 to 15% of the patients who treat are patients who had been previously irradiated, where the ideal of giving an additional course of radiation to someone who still might not have tumors spread anywhere else, and you still may be able to cure them, it's really a challenge, and a lot of those patients are getting referred to the Maryland Proton Treatment Center for retreatment. And proton therapy obviously has a greater potential to be effective in reducing some of the effects you can see with getting 2 courses of radiation.
Has there been any studies that looked at patients who received conventional radiation therapy followed by adjunctive, if you will, proton therapy, and compared their survival to patients who only receive proton therapy?
Yeah, I would say most of the studies that have been comparative studies have been patients who've gotten proton therapy versus conventional therapy. And there are many cancers where there is not only a potential for improvement in survival, such as cancers in the liver, cancers in the head and neck region, especially cancers that are near the eye or the sinuses, where we're often limited with photon treatments because of the optic nerve, right? We can't give a lot of dose because we're going to blind somebody. So protons clearly have shown improved survival. But the other thing that's just important, David, in the care of a cancer patient is, and this is what studies have also shown, is the ability to reduce acute side effects, right?
Yes.
So for example, head and neck cancer patients, nice studies in HPV-positive oropharyngeal cancers with tumors in the back of the throat, tonsil, base of tongues. 50% reduction in need of feeding tubes, reduction in need to go into the hospital because you're getting all these reactions in the front of the tongue, you can't swallow. And then the other benefits of proton therapy is not only reduction in what happens during treatment, but months to years after by reducing dose to some of these critical normal tissues. So, patients have lower dose exposure to the heart. If you're a breast cancer patient now, we've had some interesting studies from New England Journal of Medicine that showed even the low dose exposure to breast cancer patients that come with standard treatment drives enough dose into the coronary arteries that those women are at higher risk for coronary artery events. So we participate in a national study, actually a couple of my faculty are the principal investigators, that is comparing photons versus protons in hopes of reducing the risk of coronary artery events. Lung cancer is another one. So I gave examples of studies that have shown reduction in acute side effects, improvement in survival. The other good news is there are studies ongoing now where we're trying to further demonstrate reduction in its side effects as well as improvement in survival. Another study we have open, in addition to the breast cancer one, is lung cancer, right? Tumor in the lung, in the chest, surrounded by the heart, the esophagus, and many of these patients already have some compromise of their lung from maybe a previous smoking history. We're very challenged with getting enough dose to cure lung cancer. So now we participate in a national study that's looking at protons versus photons. So it's a pretty exciting time. As much as we've demonstrated the improvements in outcomes in cancers like liver, head and neck, breast, prostate, brain tumors, we continue, especially now that we have this more advanced form of proton therapy, design and conducting clinical trials that would likely only further increase the potential benefits of proton therapy across other tumor types.
Now you describe, for example, this patient with lung cancer,
Right.
I would imagine that was somebody who was presented to you as inoperable.
Yep.
So do you find that as a result of this non-invasive, safe therapy, that you get a lot of patients who are either inoperable or they're so old with other health issues they were not operative candidates under any circumstances, and you now present them a viable, non-invasive treatment alternative?
Yeah, absolutely. And for those same situations that a lung cancer patient might not be inoperable, if it's also a relatively early stage lung cancer, very high chance of curing with short courses of proton therapy. I'm talking about 3 to 5 treatments of high dose, in which this is a form of stereotactic proton therapy that we've also began doing at our center.
By stereotactic, it's very three-dimensionally guided.
Yeah, three-dimensionally guided, corrects for all kinds of motion, and can be delivered in a way that you can deliver very high doses and what we call ablate the tumor and cure them of their cancers.
Now, I would imagine some of your patients that are operative candidates, you treat with surgery, maybe chemo, and then post-operatively treat them with this elegant new therapy.
Yep.
However,
or preoperatively.
That's what I was going to bring up. Have you had patients where you treated them to shrink the tumor and render them better operative candidates?
Absolutely. I'd say give you 2 examples. So one is esophageal cancer. Clearly, we can dramatically improve the cure rate of esophageal cancer if patients can get not only radiation and chemotherapy, but surgery. One of the challenges with conventional radiation is that you can have enough dose to the heart or lungs that when they get to the OR, many of those patients become a high risk for significant post-operative complications, even death from it. With proton therapy, we can dramatically reduce the dose to the lung, heart, and show improved outcomes with the use of proton therapy. Second type of tumor, sarcomas. These are tumors that often occur in extremity muscles of the leg or arm. By reducing that splash dose of conventional radiation, dramatic reduction in wound complications. So patients aren't having issues with healing post getting a course of radiation prior to their surgery. So real helpful in those 2.
Let's take an extreme case, somebody with a brain cancer.
Okay.
A glioblastoma, multiforme, the worst type.
Yep.
Inoperable, potentially. So what can you offer that patient with proton therapy?
Okay. Well, right now there is an NCI-sponsored clinical trial that includes GBM patients, or glioblastoma patients. And one of the things we know, while there have been some improvement in the care of these patients by combining standard radiation with a newer type of chemotherapy, because of the surrounding normal brain, we're really limited how much dose we can drive. So this national study that is now open from the NCI, and since we're an NCI-sponsored center, we have that open, is looking at escalating the dose higher in patients with proton therapy. With the idea is if you can give a significant increase in dose, this is actually a 25% increase in the standard dose with proton therapy, that we can further improve the chance for cure and long-term improvement in quality of life for these patients.
Let's discuss another challenging cancer,
okay,
pancreatic cancer.
Yeah.
3%, at best 5%, 5-year survival.
All right.
What is some of the data with proton therapy and pancreatic cancer?
Right. So 2 things. One, while the survival may be limited and we can improve the short-term survival with chemotherapy, standard chemotherapy and radiation, it can be there can be some potential side effects in radiating the upper abdomen.
Right.
So what has already been demonstrated with use of proton therapy with some large series is significant reduction in those side effects, right? Difficulty with your stomach getting upset, diarrhea, things like that, reduced with proton therapy. Now we see that it's tolerated so much better. What we're going to actually open up at our center is a trial where we give the best of full-dose chemotherapy and radiation at the same time. With standard radiation, the ability to give full-dose chemotherapy for pancreatic cancer and give standard radiation while you're getting that, it's almost impossible. Patient gets sick. But we've seen such significant reduction in side effects, the clinical trial that will be activated at our center is putting the two together. So
proton therapy.
Proton therapy with standard dose chemotherapy. And that has a lot of exciting potentials, have dramatic response improvements. Many of these patients start out medically inoperable.
Sure.
So beyond improving their survival, in patients who can't have surgery from the initial presentation, we expect we're going to convert more of those patients into patients who can have surgery and therefore further drive up their cure rates.
The Whipple.
Right.
Whipple procedure. Prostate cancer.
Okay.
There's a lot of debate about which patients should be treated or just observed. Right. And then men are very concerned if they have surgery, they may lose sexual function. Yep. And even with radiation therapy, there may be some compromise. Absolutely. Plus, as a gastroenterologist, I see the complications of radiation therapy, which is radiation proctitis. The rectum is inflamed, they have bleeding, etc. What are some of the early data on proton therapy for prostate cancer?
So, particularly in patients with you made a point about controversy about who should be treated, who not should be treated, right? So clearly I think we've gotten a lot better at picking which patients become the truly higher risk patients. So if you're in that intermediate, especially high risk group of patients, there's clearly data showing significant reduction in both bowel, bladder, and rectal acute side effects, and some of the early long-term results show a reduction in those kind of side effects. One of the things that we might have the ability to do, and this is a trial and development at our center, you talked about people worrying about impotence.
Yes.
So with pencil beam scanning, that advanced form of proton therapy, we actually have a presentation at a national meeting where we've created a beam such that you can spare part of the nerve that controls the sexual activity while still treating the part of the prostate that has the tumor. So this is some of the stuff that we're excited about. So again, it's one thing to cure cancer, but most important is to cure what being least disruptive to the quality of life of a patient.
So if a patient is going to desire to be evaluated, what's involved with getting evaluated for proton therapy as opposed to radiation therapy?
Well, in our center, it's the same. We have we're very focused on the patient experience. So one, if you wanted to be seen at our center, there's a phone number you'll see and a website.
Feel free to share it with the viewers.
It's 410-369-5200, and the website is mdproton.com. A patient who calls in to be seen by our group, within 48 hours of getting their medical records, they will get seen. And we have a free concierge service. It's amazing. A lot of people will come to downtown Baltimore to see a football game. Yeah. Oh, I don't know if I want to go downtown Baltimore, which is a little surprising, but we try to make that easy. And our concierge service involves you met at the front door. It's free valet parking. We have somebody walk you through the entire experience. And last year, we actually concierged 400 patients. For patients who maybe live more than 45 minutes to an hour away and they need to get treatment daily for 5-6 weeks, we have an American Cancer Society Hope Lodge that's 2 blocks from the Proton Center that's free.
Excellent.
And patients were brought over by shuttle. If the weather's nice in downtown Baltimore, they can walk over to the center.
Dr. Regine, thank you for joining us on Housecall.
Thanks for having me. I really appreciate it.
My thanks to Dr. Regine for a terrific interview on proton therapy. My thanks to my staff here, and most of all, thank you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a very interesting one. I will have the president of the Montgomery County Medical Society, and we'll be discussing public health issues in Montgomery County and throughout the state of Maryland. It's going to be a fascinating show. See you then next time for another edition of Housecall. Good evening.